Good morning, everyone. I hope you can see me. I hope I'm not blending into the background. Okay, today we are delighted to welcome back Professor Josh Sandquist for the fourth and final lecture on you and your drugs. Thank you for being here. And normally we would say thank you lots at the end of the lecture, not at the beginning of the lecture, but while we're all ready and seated and anticipating, let me do the honors now and say we want to humbly give you a small token of our appreciation. This little certificate of appreciation for the course that you've presented. And also there's a $50 check that we're not going to give you. That will be donated to the Art Hyman Book Club. Okay? Good use of that. You would probably do that on your own anyway. So good. You're welcome. Now, a couple of other notices. You'll have evaluations on your chairs. Hope you're not sitting on them. And take time, if you would, please, because we really do. We do compile these, we read them, we pass them on to the speaker. So please do take time before the end of or at the end of the session to let us know what you thought about this series and ideas you have for future. And you can leave these on a table out in the hall, either during the break or at the end of the session. So thank you for that. Now, notice also, it's not up here anymore, but the next two sessions will be led by Professor Emeritus Bruce Boyles on influenza A virus, and registration is open for that. You can see Judy Hunter at Judy's waving in the back, at the table over break, or you can go online to register, and that starts next week. It's a 2-week presentation. Then the regular announcements, the T-coil should go on, the phones should go off. Nobody's making a move, everybody's phone is off. Oh, not yours, okay. And the mic, well, this is the style, you see. But Josh has been doing a great job of repeating people's questions, so we'll just see how that goes. Maybe you won't have to use the mic. And finally, a little bit of folklore that I thought you'd be interested in. I just discovered this. Now, it seems that if the groundhog does not see his shadow on October 30th, there are 35 more weeks of winter.
This is when we go boo.
Right. Hello, everyone. Do the mic checks. That's good. Okay. Thank you. Glad to be back here. And I was just thinking, I need to come up with another topic so I can come do another lecture some other time because I'm having so much fun on this. Thank you all for having me. I'll figure out when that will be, but I would definitely like to do it. So today we're going to wrap up our lecture learning about you and your drugs. We're going to finish something that we started last week, so I apologize for those of you who weren't here. I'll try to do my best to do like a quick catch-up so everything makes sense for you. And then we're going to move on to something kind of different for the end, but it fits the theme. So we'll start with a quick review of Lecture 3, very quick. Pick up where we left off talking about aspirin, NSAIDs, inflammation, and that was going to lead to a discussion of an example of some trouble Big Pharma had. And then finally we're going to end talking about traditional alternative medicines and thinking about them in relation to what you've learned about the last 3 lectures. So the quick review here is last week we talked about the drug development pipeline, so how we discover and develop drugs. That this is a very resource-intensive process, both in terms of time, money, people. that goes in, that factors in what the drug companies do, but also all the research that's done in academic institutions they don't even think about that forms the basis for what drug companies do. There's that tension between these sort of for-profit businesses that are private, trying to produce these products to sell. And again, what I just said, a lot of the knowledge and expertise comes out of publicly funded institutions. So that we talked about that tension a little bit. The use of genetics, how there's a lot of promise there, a lot of hope there, but we still have a ways to go. People are working on that. But the idea is eventually maybe we'll have very personalized medicine where each individual, using their genes and knowledge about that, we could give them the exact right drug or the exact right amount of drug. That's the hope. And then we talked a little bit about over-the-counter medicines. They're useful, but people need to be thoughtful about how they use them. So that's what we generally what we talked about. And then we started talking about aspirin and anti-inflammatories, inflammation. We talked about aspirin as the most popular drug, the most prescribed drug, I guess we'll put it that way, popular. And it's used for a lot of reasons. Reduce pain, reduce fever, reduce inflammation, some people take this as a blood thinner, reduce thrombotic events, lead to heart attacks. So, but we were going to focus on inflammation. And this is the really quick review for those of you maybe who were here or those of you who weren't here. New information. Inflammation is a normal process in the body. It's meant to sort of help the immune system respond to some sort of offense, whether this be an invasion of a bacteria or a burn or a cut, something like that. So it promotes, in short, opens up the blood vessels in the area where the offense occurred, lets out a lot of blood, lets in white blood cells that release a bunch of chemicals that sort of drive this inflammation process. So recruit cells to help repair the damage, help remove the bacteria, that sort of thing. And all the classic signs of inflammation that you're probably all familiar with, redness, swelling, heat, that has to do with the fact that these blood vessels are induced to become leaky in the area where the event occurred. So inflammation in the short term, when it's short and limited, is a good process. It's something that's supposed to help you heal. However, when inflammation becomes chronic, becomes long-term, it could be a main driver of several diseases or several conditions. So we'll get to those. So this is where I wanted to pick up and talk a little bit about how that signaling, that information, those information signals that drive inflammation work. Remember way back when we talked about how most drugs target these signaling pathways, either to sort of turn them on or turn them off to make things happen. So we need to understand what's normally going on in inflammation to understand how aspirin and other things target to limit inflammation. So this is where we're going to pick up. Inflammation starts, the signaling starts, this is the rate, what we call the rate limiting step. The initial step that sort of limits the whole process. So there's this molecule called arachidonic acid that is fixed or sort of embedded in that cell membrane we talked about, that membrane that surrounds all the cells. And it's stuck in that membrane, and there it's not doing anything, it's not signaling inflammation. But when there's some sort of stimulus to start inflammation, this enzyme, what we're just going to call PLA2, releases arachidonic acid from the membrane, sort of clips it and allows it to float away from the membrane inward into the cell. That's the sort of rate limiting step. After that, this arachidonic acid gets converted into a bunch of things that drive inflammation. That's sort of the rate limiting step. So this is where that stimulus, that offending stimulus comes into the process. The next thing, and these enzymes are going to be important in a little bit. This enzyme called COX, there's COX-1 and COX-2, there's two different versions of it. They convert this arachidonic acid into this other molecule called PGH2. Not terribly important to know all these details. But then PGH2 can be converted into any number of other chemicals depending on the tissue, the place that you're at where this is occurring. So, for example, in the endothelial cells that line the blood vessels, this PGH2 is converted into something called thromboxane. It tells the blood vessels to constrict. It tells the platelets to stick together and form a clot. And this is what its normal function in. If this is happening in the airways, maybe in response to you breathe in something that's sort of tickling your airways and bothering them, the major signaling molecule produced is PGD2, which causes constriction of your airways. This molecule, PGE, drives mucus production in your intestine to sort of protect your stomach from all the acid that's there. This other molecule does the opposite of thromboxane. This will dilate blood vessels, cause the platelets to not stick together. And PGF2 drives in uterine muscle, smooth muscle will cause the uterine muscle to contract. And this has actually been used as an abortifactant for those because of that property. So, point here is where you have the same starting point. This arachidonic acid is released. COX-1 or COX-2 converts it into this molecule. That's similar to all of these, but then after that it diverges depending on what tissue you're in and what's happening. It gets pretty complex. I just wanted to give you a general idea of the complexity here, and we're going to come back to a couple of these ideas in a little bit. The last point, well, I had this here so I didn't forget to say, keep in mind that many of these things are not part of the inflammation process, although they can be. Many of these are what we call housekeeping functions. They're normally just going on in the body, keeping the house in order. You have to modulate, you have to keep making the mucus in your stomach, or keep the blood vessels at the right dilation. So this is just stuff that's going on all the time, regardless of whether or not there's inflammation. Okay, so we're going to come back to these COX enzymes here, because these enzymes there are the target of aspirin and the other NSAIDs. The other NSAID stands for non-steroidal anti-inflammatory drug. So there are other drugs that decrease inflammation, steroids, like many people have probably heard of taking steroids for inflammation. But these are a class of non-steroidal drugs. And these all work by inhibiting this enzyme. So even if you have inflammation and this arachidonic acid is produced, you're slowing down the production of this guy so you don't get all those other things that drive the inflammation process. Now it's important for the rest of our discussion that we know that COX-1 and COX-2 are similar in that they both convert arachidonic acid into this next molecule, but they're different in some important ways. COX-1 is what we say is constitutively expressed in all tissues. Constitutively means it's just always there all the time. It's just, there's a basic level of it constantly there. And this generates the prostanoids, all those molecules at the bottom of the chart that I showed you a minute ago. COX-1 is important for generating all those for the housekeeping functions. So COX-1 is there doing all this all the time, making sure your right chemicals made to keep the body in working order. It can be a part of the inflammation process too, as an additive if this inflammation response is stimulated, but basically it's just there all the time. COX-2 is not there all the time. It specifically comes up when there's an inflammatory signal to sort of enhance that inflammatory response. And it doesn't participate in all, it does maybe some, but it doesn't really participate in all of these housekeeping functions. So hopefully the reason I'm explaining this will make sense in a few minutes. So we're going to go off on a tangent here and talk about some pathologies that involve inflammation, then we'll come back to how the aspirin and things are used. So here are some examples of major pathologies or disease that inflammation is a large part of them. Asthma, inflammatory bowel disease, rheumatoid arthritis and gout, some cardiovascular disease, so atherosclerosis, if people have heard of that. That's basically an inflammatory process inside of the blood vessels. Cancer, and there's a major component of inflammation involved in cancer. I don't have time to really go into all of these. I'm just going to focus on one in order to give an example of how chronic inflammation can create a problem. I'm going to talk about rheumatoid arthritis. So this is a chronic disease. It's systemic, meaning it has effects all throughout the entire body. And it involves sort of an autoimmunity component and inflammation. Autoimmunity, if you don't know, means that your body's sort of attacking itself. It's not supposed to do that, but it'll recognize itself as parts of it as a foreign entity and want to respond to that. Largely affects the joints, but in severe cases, skin, cardiovascular system, lung, and muscles can also be impacted by this condition. The etiology, or how it, sort of just the disease mechanism, they said the body has an autoimmune response. It's targeting what's called the synovium in joints and other tissues, so that could be in muscles. So what's the synovium? This is sort of a drawing of like a knee joint, let's say. You have the upper bone, the lower bone. There's a space between the bones. That's the joint space. There's some cartilage, that's the blue stuff lining the bone. There's fluid in this space to sort of lubricate the joints. And this darker pink thing here is what's called the synovium, or the synovial membrane. That sort of wraps up this joint, keeps that fluid in there. This is what's being attacked in rheumatoid arthritis. The body thinks that this is foreign and starts attacking this membrane here. And that starts inflammation in the joint. So what happens when there's inflammation in the joint? Well, you get the release of these molecules called cytokines that we talked about. COX-2 wasn't there before, but now it becomes active and starts to promote inflammation. By doing what it does, it converts that arachidonic acid molecule into the other things. Some of the molecules, maybe if you remember PGE2 gets produced, that's one of the molecules that's on the list. That sort of signals pain response, but there's a bunch of other stuff that's made. And what happens is, remember inflammation, imagine a cut. You get inflammation there. Part of the inflammation response is to recruit cells that will repair that tissue. Well, the body doesn't know that this is a bogus inflammatory signal because it's not immune and the tissue's normal, it's fine, but it doesn't realize that. So it brings in cells to try to repair the tissue, the damage that it thinks exists there. So macrophages are a type of cell type. They secrete enzymes that sort of break down tissue in order to repair it, which would be useful in a situation where if you had a cut, but it's not useful in a normal healthy joint. So what happens is you get this cycle of inflammation. After this is the normal looking joint, this is one that's undergoing rheumatoid arthritis here. Once the body sort of recognizes synovium as a problem and starts attacking it, it recruits those other cells that try to remodel the tissue, which then actually just creates damage, which then creates more inflammatory signal, which recruits more stuff, and you just get this snowballing of inflammation and tissue damage. This is the problem when inflammation becomes chronic. It's just around all the time, creating havoc rather than cleaning up a mess like it should be when it's short. So this is, and then you can imagine the same idea just playing out in a lot of different ways in the atherosclerosis that I mentioned, or asthma or cancer. The same idea. You get this trigger and you start this response, it spirals downward. So, now we're going to go back to, now that we understand a little bit about how inflammation can be bad, let's think about how we use NSAIDs to treat it. This is my remedial drawing of the enzyme COX-1 or 2. And you can imagine inside of this enzyme, there's a space or a cleft. And this arachidonic acid molecule, remember the AA that gets produced as that first rate-limiting step in inflammation? When that gets produced, oh yeah, I have the drawing here. So that's the arachidonic acid here. What happens is that goes up into that cleft, finds a site in the enzyme that can do the chemistry to convert the arachidonic acid into the next thing. So this arachidonic acid needs to go up in that cleft and be worked on there. So what NSAIDs do, in a sort of simplified way, is they bind there and block the arachidonic acid from going in. Sounds pretty simple in premise, right? Aspirin's a little unique. That's why I say aspirin and NSAIDs, because it's not exactly the same. It has the same target, but it works by a pretty different way. So aspirin actually goes in and chemically modifies an area around that active site so it can't function. So it doesn't just block the hole, it actually modifies the enzyme permanently in terms of makes it non-functional. So aspirin's a little different, but it has the same target. Now remember, we talked about COX-1 and COX-2. So COX-1 is the enzyme doing all those normal housekeeping functions, and COX-2 the one that really gets the inflammation burning, right? So COX-1 and COX-2 are pretty similar. They do the same thing. But they're slightly different in their design. I don't know if you can see my drawing here, it's a little subtle. If you watch this area here, there's kind of, the COX-1 has a little bit of a narrower opening than COX-2, among some other minor differences. But this is what we're exploiting with drugs. So there's a little bit of a narrower opening there. And so these NSAIDs can work to block both COX-1 and COX-2. So, but there's sort of a difference in how well they do this. Ibuprofen may hit both of them kind of equally. Naproxen may hit COX-2 a little bit more than COX-1, but it does both. Aspirin does them both more or less equally, maybe a little bit more selective for COX-1. But in general, most of the NSAIDs we use, to some degree, will turn off both of these. Remember, COX-1 does the housekeeping, and COX-2 does the inflammation. So people have realized maybe we can use this difference in COX-1 and COX-2 to a benefit. How many people have heard of NSAIDs causing GI problems? Acid, disruption of the stomach. They wanted to see if we could exploit this difference between COX-1 and COX-2 to limit that. Here's the thinking. It was in 1971, Sir John Vane discovered that aspirin and the other NSAIDs block that prostaglandin synthesis. All that stuff that I just told you, he's the one that discovered that that's what it did basically, to block those prostaglandins from being formed. It was later found, these housekeeping functions, so that one prostaglandin that I told you about that drives the mucus production, it does more than that. It actually reduces the acid secretion in the stomach. It covers the lining of the stomach with mucus. It reduces the permeability of the epithelium, so less acid seeps through into the inside, damaging the underlying tissues. It increases blood flow there to kind of keep that layer of cells healthy. And it also brings in a molecule called bicarbonate, which is a base to sort of counteract the acid to keep it from being so strong. And COX-1 is the dominant enzyme in these cells of the stomach that drive all this. So the thinking was, well, if we could inhibit COX-2, we could stop inflammation, and if our drug didn't inhibit COX-1, it would leave the stomach fine, and you wouldn't have that bad GI problems that happens when you take aspirin or other NSAIDs for long periods of time. So if we could just target COX-2, we'd have a real moneymaker, right? Because then people could take this and for the rheumatoid arthritis forever and they would never have any stomach problems. So that was the thinking. And that was the hypothesis. If we had an NSAID that only inhibited COX-2, it might decrease inflammation without causing GI problems. So the question was, could they make something that would do that, that would block that and not block that? People remember Vioxx and Celebrex? That's what those things are. Those are COX-2 selective inhibitors. They were the product of that hypothesis, thinking, can we find drugs that'll block only COX-2 and not COX-1? Now, Vioxx you can't get anymore. Celebrex is sold in limited circumstances because there was we'll say, an unanticipated side effect. The reason I put unanticipated in quotes is because in hindsight, I think if you look at what we knew about how these things work, someone really thoughtful, really focusing on this might have been able to predict it, but you could give them the benefit of the doubt and say that they didn't foresee these things coming. But as you'll see, even when there was evidence that there were heart problems, people sort of swept it under the rug, and that was where the problem came in. So COXIBs, that's the short for COX-2 inhibitors, these selective inhibitors that inhibit only COX-2 and not COX-1. They had serious side effects on the cardiovascular system that caused them to be pulled off the market. How did this work? So remember this whole slew of molecules that could be made downstream of that COX enzyme, depending on the tissue. Well, if you take aspirin, it's going to go everywhere throughout the body, so it's going to affect the production of all of these things all over the body, right? Not just the inflammation in your knee, because as we talked about a couple lectures ago, once it gets into the bloodstream, the drug goes everywhere. I'm only going to focus on a couple of these for clarity. So there was this drug, PGE, that did the gastric mucus, this molecule, thromboxane, which promoted vasoconstriction and platelet activation, and PGI2, which did the opposite of thromboxane. So here's what we had with NSAIDs. Basically, the NSAIDs blocked COX-1 and COX-2, so all of this went down. Less inflammation, but you also had less mucus productions, you had GI problems. You decreased this guy, which is actually kind of bad, because this promoted dilation and blocked platelets from coming together. So that's actually a negative for your heart. But it also blocked this thromboxane, which did the opposite, and that's kind of a good for your heart. So those equaled out, so there wasn't too much of a problem. The Vioxx and Celebrex that they designed did as they had hoped. It blocked inflammation and didn't block mucus production, so that was good, a win for rational design. The problem that was not fully foreseen was that it blocked PGI production. Remember, PGI, we'll just say simply, is good for the heart, because these things that it does is good for the heart. So it blocked that guy, but it didn't block the stuff that was bad for your heart. So it ended up having an overall negative of promoting sort of blood thickening, we'll just say. That's the opposite of blood thinning. So you got more clots in the blood and led to these heart attacks, these thrombotic events. So there's a really interesting story. Hopefully I make this big enough. If you go and watch the video later and find this web address, you can write it down and go to the full story. We'll talk about it just a little bit here. This is an interesting timeline on the rise and fall of Vioxx. So Vioxx was a product of Merck. And this goes through talking about how Merck thought of the drug, designed the drug, and started doing these clinical trials. So, let me see here. I wanted to highlight a couple things. So, in November of 1998 is when Merck first asked the FDA for approval to start doing these clinical trials on it. Or for approval of the drug. It had already done some clinical trials. And at that point, only 5,400 subjects had seen the drug. So there's now a review of the data from the clinical trials. And the short of it is that there was some evidence that there was an increase. So they were comparing Vioxx to naproxen sodium, which is Aleve. And there was some evidence that the Vioxx was causing some more heart attacks than naproxen. Now the people at Merck, they foresaw, as I said, Vioxx being a huge moneymaker, so that's not the type of results they wanted to see. And they found ways to justify it. I can't remember, it says it somewhere down here. They thought it wasn't so much that, they said, wasn't so much that Vioxx was causing more heart attacks, it was that naproxen was sort of protecting from some. So that was the basis for the difference. It wasn't actually caused by Vioxx. That's what they said. You'll read on and you'll find there's some hairy things going on. So there's someone in the FDA who ends up also having a lot of stock in Merck, those sort of things. Basically, they push it out onto the market, and then they start seeing people, there's this increase in heart attack events. And then some other people started doing more studies. It raised some questions about the New England Journal of Medicine because they had published the results from this and didn't catch, that small amount or that relative, that significant, small but significant increase in heart attacks. So this is just sort of a study in how the profit motive in big pharma can create problems when they're almost there. They've already put in 99% of the work and the expense in making this drug. And there's just a small, maybe a small side effect that they can kind of disappear if they squint just right, and how that pushed them, and then it's sort of a failure in the systems that we're supposed to overlook and oversee all this. So this is interesting. It's not terribly long. It's just sort of this timeline, but it's an interesting story. Some problems that can happen in big pharma. So I went through that. I wasn't sure how long that would take me. I'm going to transition now into sort of the final topic. But maybe I'll just see if since there's a lot of stuff there, if anyone had any questions about what I just covered before we move on, sort of transition into a new idea. Yeah.
Earlier you had the word upregulated. Was that a typo, or was it supposed to be unregulated?
Yes, the question was I had the word upregulated, and that was relative to COX-2. So upregulated means that normally the levels of it's regulated such that the levels are low, but when there's inflammation, it gets upregulated, so the amount of the COX-2 enzyme goes up. So that, there's upregulated, downregulated, those sort of terms. Yeah.
The reason I think that Celebrex is still on the market, but Vioxx has been withdrawn under a dark cloud, is that there's a known chemical reaction that Vioxx undergoes that then turns it into an irreversible enzyme inhibitor, and that was implicated in its malperformance. And Celebrex doesn't have that property.
Right. So thank you for bringing that up. So the question/statement was that there's a little bit more to this story than what I just explained, in that these effects that I just described of Vioxx and the COX-2 inhibitors on the signaling and inflammation are accurate. But in addition, we talked about metabolism a little while ago. Vioxx is metabolized, and it creates a metabolic product, a breakdown product that is also responsible for some of its bad side effects. and that's why it was taken off the market and not Celebrex. That's true, and I mean, and there's been more studies looking at how much worse is Celebrex and these COX-2 inhibitors than, say, naproxen, and actually in terms of heart effects. And afterwards, after this, they've gone back and looked at NSAIDs a little bit more and said, oh, maybe there is a little bit more heart risk there than we originally thought. It wasn't creating an obvious increase in heart attacks, but maybe there were some issues there. So people have begun to look at these a little bit more, and then overall it's just created a little bit more carefulness about the use of these things. Thank you for bringing that up.
Gosh, so often, counterintuitively, when you have an ad on TV for a drug, they'll mostly list the side effects. I assume what's going on here is the side effects are not severe enough or frequent enough to take it off the market, but they're protecting themselves legally. But it always seems, they don't tell you much about what the drug's going to do for you, but they tell you what it's going to do.
Right, so George is pointing out the fact that when you see commercials, a lot of times it doesn't really say what the drug is for. You'll see people riding on horses in sunshiny backgrounds. And then there'll be this list of side effects at the end. And is that just them covering themselves legally? That's part of it. There's also some really specific rules about how you can advertise drugs. And you're not supposed to directly advertise a use to the consumer. So the consumer doesn't necessarily go and like clamor, ask the doctor for it. So there's some careful regulations about what you can actually say a drug can do in the advertising. So that's part of that as well. There might have been some recent changes on exactly how that is, and how that's enforced. And I mean, there's ways that people find out what the drug's for, even if it doesn't say it in a commercial on TV. So they're getting around that a little bit. I think that's a little bit of what you're getting at there. Yes.
When you talk about them reanalyzing things, when something goes wrong, they go back and look at it. Is that the drug company that does that, or the academic?
So the question was who, when we start finding out that things are going wrong, who goes back and reanalyzes? So in the case of Vioxx here, they're going through these clinical trials. Now there's a bunch of these data are just out there, and someone else can come in and look at these data and apply a different statistical filter to them, or look at them in a different way and see if they can find stuff. If something goes on the market, Merck is still responsible to keep track of side effects that creep up and try to determine if there's anything there or not. So the answer to all the above. Whoever's interested and can get funded to drive that research probably will. Maybe we'll take one more question and then we'll do the break. I think I saw, sorry, sir, do you want to go?
I'm actually going to comment, listing all those, why not just say, well, it might kill you.
Oh, yeah. Comment was, why not just say, might kill you? I probably wouldn't sell very much of it that way. That was a quick one, why don't we go pick one?
Has anything been developed to replace Vioxx and Celebrex?
I think there, okay, I'm sorry, thank you. The question was, have other things been developed to replace Vioxx and Celebrex? And I can't remember, I don't know is a good, the main answer. I don't know, I'm sure there's been other work done on the COX-2 inhibitors, selective, but if the mechanism is, if you inhibit COX-2 and not COX-1, and that's going to create problems, then that's just a fundamental problem with the concept of the drug, and there might not be a lot of work in there, and then of course they have to sell it. And then they'll be competing with Celebrex, which is already out there on the market. So I don't know how much is going into that right now. That's a good question. So let's take our break.
Yeah. Thank you. We'll take a 10-minute break, listen for the cowbell.
Thank you. Not on? Now's it on? All right, thank you. Took a second. Thanks. All right, so we're going to end talking about something a little different. I hope this is sort of fun and interesting, but it's just something I've been thinking about a little bit more, and I taught a new course, a global learning course last spring, centered on this idea of traditional or alternative medicines. So I want to wrap up the course thinking about this, sort of juxtapose it against, we've really only been talking about one medicinal system so far, the one that's prevalent in the United States, and one that's driven by medicines that are highly purified, single active ingredients that act in a very specific way that's grounded in physiology. But there are other medicinal systems out there that don't have a different framework. And I think there's been a growing interest in those lately, so I think it's important to talk and think about those a little bit. And I'm not trying to talk about them in any sort of value judgment sort of way right now, because I'm not saying that they're bad, they're just different, okay? And so I just want to talk about them a little bit. So, I think you can highlight the thing that I'm talking about now with this, just looking at the packaging of these two things. So we talked about how aspirin is a purified, modified form of a salicylate that was originally found in the bark of willow trees. So people can take something out of this cold, sterile-looking box, or this exciting-looking bottle that has the word nature on it, right? So that's the idea that we're thinking about now. You can take this willow bark. It happens to be a capsule, so it's just ground up willow bark that you can swallow, but there's also teas that are formulated. At least one of the chemicals in there is essentially the exact same thing as aspirin, but the bark of a willow tree is going to have thousands and thousands of other chemicals too. So that's a major distinction between those two. And this idea that it's natural, we're going to come back to that a little bit. So, a very general comparison is in terms, first of all, I don't want to be sort of biased in the terminology. We have to use words to define things. I'm using the words, you'll often see modern Western medicine or Western medicine describing basically the system that we've been talking about the last 3 weeks with what's prevalent in the United States and the westernized countries. So again, this is based on sort of purified, single active ingredients, embraces the reductionist philosophy. That's the idea. We want to reduce this down to the simplest thing possible, one single chemical. So we can very carefully determine, is that chemical doing what we think it's doing? So the founding principle of Western medicine, if I had to say one, is probably reductionism. Let's simplify this as much as possible so we can understand it. Now, the other systems we're going to talk about fall into the category of what you might call traditional or complementary and alternative medicine, abbreviated as CAM. A lot of times people throw around the word alternative medicine, which isn't one that I particularly like, because it makes it seem sort of less than as an alternative to the idealized Western system. That's not the way I'm using that word. But CAM seems to be the accepted term published in books by people who are sympathetic to these sort of systems. So it seems to be the word that people use. This is viewed as a more holistic approach, treating the person, not the disease. So in the West, you might say, what's your condition? I'm going to treat that condition. Whereas in some of these other systems, they're treating the person. I want to unpack what that means in a little bit. Particularly these traditional systems, they're more useful in minor or self-limiting disorders, aches, pains, GI problems, childbirth. There's a lot of, because these are developed over millennia before we had instruments to measure things. So the conditions that these were used on, that people could accurately diagnose and work for, were more of these sort of mild, more limiting conditions. The childbirth is a really big one. So over the course of human history, childbirth was actually a very dangerous thing for people. An important aspect of this is that, well, the theory is a little bit difficult to prove. A lot of these are based on this idea of sort of being there a life force that's in harmony or balance, and sort of there's different axes that you can measure of a human. Are they balanced along those axes? And as such, a person's condition is a little bit in flux. It's dynamic. It's not you have the disease or not. You have a certain condition about you that we're going to work on. So it's a little bit different framework. And as such, the condition changes over time, and the treatment necessarily needs to respond to that and change over time as well. As I said, the diagnoses are done without instruments. Palpitations or touching. We're going to look at this a little bit later, examining someone's tongue. That's sort of a really common feature. Some of these. So there's different things that people are just gleaning with their natural senses, and then a lot of intuition born out of years of experience. And again, I don't mean to say intuition is make that sound bad or it's not productive or powerful. Maybe you've had the good fortune of working with a doctor who is just really intuitive about determining what's going on with you. You can just expand that out in these, without even having to measure what's in your blood or something. And then again, a key difference that we've already sort of mentioned is that the treatments are generally very complex mixtures, often taken as teas. They're usually plant-based, but sometimes insects, animal parts, or minerals are also included in there. This is this complex of a lot of different stuff, which is the antithesis of the reductionist approach that we just mentioned. So first of all, on approach this idea, I read an interesting article. Why not call modern medicine alternative? If you think about a lot of what our medicine in the West came out of, it looks different now, as the Greek tradition, thousands of years ago. Hippocrates is generally credited with sort of popularizing this idea of the four humors. If anyone's heard of humoral theory, bodily fluids that have to be in balance. We'll go that in a minute. And then Galen also sort of another Greek drove sort of to popularize this. So again, this existed for thousands of years. And so you might view, and it still exists today, even though it's sort of gone up and down in popularity, it still exists today. So some people might view modern Western medicine as sort of a late-coming alternative to the long-term prevalent humoral theory. So why not call modern medicine alternative medicine? And to me, this drives us, some folks who are really strongly advocating for taking a look at these other medical systems, and particularly folks who live in the West are trying to say, let's look at these other things, will sometimes kind of frame it that way. Why not let's just think of the modern scientific approach as another alternative to a way we can medicate ourselves. The positive take on that, I think, is that it's practical to treat patients by any means that's effective. So don't rule anything out just because of whatever system it has to be labeled in. The danger with this way of thinking, in my mind, at least today, these things could change, is that it sort of undermines the value of all the scientific expertise and knowledge that goes into supporting the effectiveness of our modern Western medicine. And I think you can see this playing out in the vaccination arguments that are going on, and even if you want to think more broadly of the medicine, climate change denial, this sort of denial of undermining of scientific expertise in order to promote an alternative theory that they're trying to give with equal weight, saying that basically all alternatives should be considered equally. I think that's a dangerous way of thinking. But again, I'm not saying that to automatically undermine these alternative systems either. So let's talk about a few of these alternative medical systems. Just quickly by name. Western herbal medicines, that's something that's really still popular in Europe, some in the United States as well. Herbalism that you've heard about. That's sort of what the modern medicine kind of came out of I talked about this before in the first lecture, as we started to understand physiology better and purify chemicals out of foxglove, we got what we have today. That kind of came out of this herbalism, which again came out of the Hippocratic tradition. Asian systems are, traditional Chinese medicine or TCM goes back 5,000 years or more. It's really old, really broad, really unwieldy, I think. The main basis behind this is this idea of qi, a life force, and these five elements, or ways that people could be balanced on, sort of yin and yang along these different axes. Wood is wood's associated with the liver, earth is associated with the spleen. So there's a philosophy and a theory to it, but it's pretty sprawling. And because it's so old, a lot of stuff has sort of been added to it over time, sort of uncritically, and it's a little bit hard to wrap your head around now, I think. Campo, which we're going to focus on, is an outgrowth of Chinese medicine and goes back to maybe 500 or 600 AD, when the communication between China and Japan brought Chinese medicine over to Japan. It's grown into something quite different, and this is what we're going to focus on today. I just want to mention a couple of other ones. Ayurveda is really becoming popular again. This has herbals involved, but also things like yoga and breathing and massaging, acupuncture. So it's a little bit broader than just medicines. Also don't want to forget that there is African, Native American, and then what there's often called like Oceanian, like, traditional medicines out of Australia and different places or islands. So there's all kinds of medical systems all over the world. That's the main point of this slide. But we're going to focus on Campo, because that's something I learned a little bit more about through the course of teaching this course in the spring. So Campo was introduced from China in the 6th century, and there was ongoing cultural exchange, and it's thought that it probably didn't differ from Chinese version for maybe 1,000 years, because it didn't develop much on its own. There was a lot of cultural exchange. Then in the 18th century, in the Tokugawa era, Japan experienced a cultural renaissance of sorts. It sort of had a tinge of nationalism, and they started to close off from the outside world and develop more things that were inherently Japanese. There was still communication with Japan, but a little bit less just directly following what they were, or with China, but a little bit less directly following what they were doing. So as a result, Campo started to differentiate from traditional Chinese medicine. Just real quick, what are some of the differences? As I mentioned, the TCM is pretty sprawling, based on this yin-yang and 5 elements, but it's a lot broader than that. But it is pretty deeply ideological. When someone's giving a medicine in TCM, it has to be firmly rooted in this yin-yang 5 elements theory. There's not really there's not another way to really go about prescribing things. So it's deeply ideological in that regard. Campo is less so. It's a bit more practical or pragmatic, I think. It's developed over a long time, and as I said, had that broad incorporation, different approaches. It was complicated. So in short, I think you can think of Campo as sort of a simplified, pragmatic version of TCM. Even though they may still use Chinese herbals in Campo, they're not necessarily used in the same way under the TCM philosophy. It sort of developed its own philosophy. It looks very similar to TCM, but it's different and narrower. So that's what happened when they started to split from TCM. This again happened during the Tokugawa era. And during this time, so this is the 1700s going on, Japan, as I said, really excluded the outside world, except weirdly the Dutch. They communicated with the Dutch, they incorporated Dutch medicine, heavily influenced their system. And I don't know why exactly only the Dutch were allowed to trade with them and get in, but for a long time, there was no one from the West except the Dutch. Japan was looking at things like the Opium Wars between Britain and China and just thought, we don't want any of that mess, we don't want to get involved with the West. So they tried to keep themselves closed off for as long as they could. And that allowed Campo to evolve on its own. But eventually in the 1850s, the US sort of forced an opening in Japan. They wanted to establish the island as a place that they could stock up on trade routes, and also a little geopolitical reasons. So basically, some people showed up with some warships and gave them an ultimatum, said, we're coming back in a year, you better let our ships restock here on their way to China and whatnot, and that opened up Japan to the west. Not long after that, in the 1860s, there was a period called the Meiji Restoration. And so what this is, it's sort of political, but it has consequences for what we're talking about. In Japan, there's different sort of ruling systems. There's a imperial family, a king and a queen, But there was also this warrior class called the shogunate, and for a long time, I think maybe from like the 700s, 800s-ish onward, the shogunate was really more in control. The imperial family existed, but it wasn't really doing much. Wasn't really even seen as being in power. But in 1868, that changed. The shogunate ceded power, or the imperial family wrested control back, however you want to look at it. And the imperial family took over again. And the first Meiji ruler saw the power of the West, and they wanted to sort of embrace that as a way to be seen and taken seriously by the West. Because right now they've been closed off, they were worried that they were viewed as sort of this minor island country, not really powerful. So they wanted to embrace, there was this phrase that was common in the period called something like catch up and overtake. They were really pragmatic about taking in whatever seemed to be useful from other cultures and other societies and taking advantage of it. So it opened up to the West, and in fact it went so far as, at this time they saw the power of germ theory. We had germ theory at this time. Military surgery was seen as super effective. Vaccinations. It just made, at least to the ruling class, Campo look really backwards and small. And so Campo practitioners weren't allowed to be licensed doctors at this time. And they fully embraced Western medicine. Campo still existed, but it was really kind of hung around as a part of Japanese culture. People still patronized Campo doctors, but again, they weren't licensed medical professionals. So that sort of brought us up into the last recent decades. Maybe in the 70s or so, there started to be a renaissance in Campo. Started to be taken more seriously, partly because there was a shift in attitude towards Western synthesized chemicals seen as sort of impure, partly changing demographics, aging population. People weren't really dying of infections anymore, so the power of the germ theory didn't really seem that big a deal. And Campo as a result, Campo formulations started to be recognized by Japan's National Health Service. Campo doctors were allowed to practice. And today you have a pretty highly integrated system where both sort of exist together, which is unique. There's not a lot of countries where you have the traditional system held on a level about par with the Western system. It's either sort of one or the other. So in recent years, so this has been in Japan for the last few decades, and then more recently, the West has started to look to some of these traditional medicines and see what's there. And you wonder what's driving that. Some people hypothesize that it's a symptom of maybe disenchantment with modern medicine. Natural just sounds better and safer. Again, this idea of chemicals being bad. Also, the medical system now is super expensive. People are becoming disillusioned. Kind of maybe seen as there's a lot of testing, a lot of overprescription going on. We just bought too hard into this drug idea. And again, the focus on treating a disease and not the patient. So some people suspect that maybe we started to bore or tire of this approach. They start looking to other systems. There's also, I think, this idealized idea of ancient wisdom, the natural way, sort of seems appealing to some people. But the Western medical establishment is less enthusiastic about embracing some of these traditional systems. Why is that? Well, I think partly there's a conflation with these fad medicines. So there are a lot of non-evidence-based systems out there that are being promoted because maybe they can make a quick buck, because they don't really have a theory driving them. So something serious like Campo is kind of wrapped up, viewed, and tainted because of that idea. Partly, I think it's because of deep philosophical divides on the importance of reductionism. In the West, we need a pure chemical so we can really understand what it's doing. Who knows, when you take willow bark, there's thousands of chemicals. How can we know what's doing what? And so, but a lot of these traditional systems really sort of embrace strongly the idea that there's multiple ingredients because they're working all together. So it's a completely different sort of philosophy. And also sort of on the practical level, health insurance providers, be it the government or a company, have only limited resources, and they want proof a treatment's going to work before they're going to pay for it, right? And as we'll get into, I read a lot of this person, Katsutoshi Terasawa, Japanese man, trained in Western MD, also trained as a Campo practitioner, wrote a series of articles. He was very influential in this 1970s resurgence in Campo. He wrote a series of articles that I found really compelling. And he argues that this sort of one-size-fits-all measurement of efficacy that we have in the United States, that's really based on this clinical trial, just doesn't work with Japanese medicines. Just by the way that they work and the way that Campo's practiced, a clinical trial it's just not the appropriate way to test efficacy. And so because we have a hard time testing efficacy of Campo treatments, people in the West are a little bit loath to accept them as a treatment. Why is that? So here's a picture of one of my students. We met with this gentleman. He's a practicing Campo doctor teaching at a university in Japan. And he gave a demonstration of how a Campo doctor would diagnose a patient. So he did a lot of touching, feeling the hands, looking at the tongue, pressing on different parts of the stomach. And so he showed us how you would diagnose what's called a person's show. That's the Campo diagnosis. It's not exactly the same as what we would call disease in the West. It doesn't have an exact corollary, but it's closer than maybe some other traditional systems. So the show, one way of thinking is just your current sort of state. It goes to this idea that there's a balance that you want to be in, and you could be out of balance in a couple different ways. And your show is kind of where you sit on those multiple axes of measurement. And so everyone has one, regardless of whether or not you're sick. And so then the treatment is meant to sort of nudge you back to a place of balance. The idea being, if it gets you back to balance, then you can fight off whatever condition's bothering you. It's not that they're treating the condition. And as such, as your show changes, then your treatment might need to change because it might need to nudge you in a different way. Also, because of the limited measurements that are taken, some people may have similar shows but have different treatments are actually needed to nudge them in the right way. So it's a little bit hard to shoehorn this system into our clinical trial where someone has to come in and say, yes, you have 50% less of this enzyme in your body, so we know you have this disease, and now we're going to test this very specific chemical on that. This diagnosis and the way the treatment shifts over time, so fluid and dynamic, Terasawa argues this just doesn't fit into how the West can evaluate effectiveness. So that's why it's been discarded, or not really respected so much. That's a good transition into, I'm going to talk a little bit more about the trip that we took on this and how I learned a little bit about this. I've read some articles. That's great, actually going someplace and meeting people and learning more. So we took, a colleague of mine took 14 students to Japan. We spent very little time in Tokyo. We actually spent more time down here in this part of the island, Osaka. We didn't actually go to Osaka, but there's a town by the name of Kyoto and Nara, which are both down there. Those have importance. And we spent time up here in Toyama. I suspect many of you might have heard of Kyoto and Nara, but not very many of you have heard of Toyama. This is a little bit more of a backwater place, not traditional Western sort of place where people go for vacation. But there are mountains here. It's called like the Japanese Alps. It sits right on the edge of these mountains and on the Toyama Bay. Very interesting, beautiful place, and important in Japanese medical history. Not one many people go to. So our story starts in Nara. Has anyone been to Japan or been to Nara? You know, a few Japans, maybe Naras. If you've heard of Nara, you've probably heard of the deer that just sort of live wild there in town. Very friendly until you try to feed one, and another one really wants the food, and then you might get in trouble. So the advice is to not even look like you're trying to feed them. These folks are really nice. They were giving us directions to the temple we were trying to look for. But really, the first thing I want to tell you about is this large Buddhist temple called the Todaiji. This wasn't just, again, a site where we went to because it looks really cool. This actually has an importance in the medical history of Japan, Campo. So these Buddhist temples, the thing that's known for inside this really big building is a big Buddha statue. So here's a picture for scale, and here's another picture. I think I read that from the base of the hand to the fingertip is like 7 feet. So that gives you an idea of how large this statue is inside this building. So Nara has an interesting place in the history of Japanese Campo medicine. In 700 or so, Nara was the capital of Japan, so it's the oldest, I think, known capital of Japan. It's still sort of around. And there was an empress, Komyo, in the 700s that was really taken with Buddhism. Buddhism had started to grow in popularity at the time. And she, through sort of her, as an outgrowth of her Buddhist faith and an increasing development of sort of this Campo medicine, she started setting up basically free dispensaries to the poor using the Buddhist temples as sites where this was administered. And they actually kept and stored a lot of there were gardens and there were storages for these medicines here. So this is an outgrowth of the Buddhist philosophy, sort of administration to the poor. That's deeply bound up in the history of Campo. So we met with some officials in Nara that told us a lot about this. And one of the sites where the original sort of storage gardens for Campo is thought to be that pagoda there in the background of the window. But these are some folks. Nara is really interested in sort of reclaiming this history of Campo. Because as I said, the Western medicine is really sort of taken over. And even though there's a renaissance in that, the current younger generation is even getting less and less interested, more and more interested in Western outside influences. So it's still kind of at a tipping point. But folks like these are truly trying to redevelop Campo's history. One of the interesting things that I thought about, yeah?
Is the face mask because of air pollution?
No, it's not. The air's not polluted at all. I think a lot of Japanese folks are very high on cleanliness and not sharing germs. So it's probably just that this guy was a little under the weather and he didn't want to spread his germs with people. So one of the things that these folks were really examining was bringing back or expanding on this idea of home delivery. So here's a statue representing what hundreds and hundreds of years ago, a Campo medicine delivery person. It was called home delivery, and there was this phrase, use first, pay later, where they were delivering medicine to farmers kind of spread over the countryside. They were bringing these medicines out, and they may not know what they need at the time. So they would basically just leave a bunch of medicine with you, continue on their right, come back a year later, and then ask you to pay for what you used. So it was a much more economical way for poor people to buy medicine rather than buying a bunch of stuff that they may not need. So they were trying to bring that back, which is a little bit hard because there are few people that really want to do that sort of thing today. In Nara, we met with this guy who is the 24th in a line of his family, 24th generation, to run this pharmacy here. It's a Campo pharmacy. He was a really interesting and nice fellow. These are just some of the windows showing his pharmacy. We left from Nara and went up to Toyama. Between Nara and Toyama are the two places where Campo is still sort of has a deep history and is still really being kept vibrant. An interesting story, this is a little display in a museum there. The idea behind the history of why Toyama is so important in medicine, the story is that all these shoguns got together for some sort of important meeting, and this guy had a stomach ache. I think this doll is actually quite expressive. And this is the local person from Toyama that says, take our local medicine, and it made him feel better right away. And you can still buy that local medicine today. I tried some. A key ingredient is bear gallbladder, which isn't very common anymore, so now I think they use it from cows. It's really bitter and really sticky. Evidently it's supposed to help with your stomach and also if you overdrink. be used. Someone here told us about how Campo was advertised, its history today. Interesting things like the packaging. See all these people that look kind of like the weebles that wobble but won't fall down? When you see that on there, that is advertising like a cold medicine, because it may knock you off your feet, but this will help you bounce back up. There's all kinds of different symbols that they use in their packaging. Here's a video of, we went to another museum, of a guy showing how the medicine, oh, it's really slow. So we put this paste back here in sort of this hopper, and he presses down on it, and it sneaks kind of like the Play-Doh, and he'll just chop off a bunch of those little lines, and then he takes this.
One piece.
Okay.
He takes this little board and presses down and kind of rolls them all at once into the pill-shaped form, and then lets them dry. So that was a fast way of making a bunch of different pills at once. So that was a cool demonstration we saw. Oh, stop. I want to move on. There we go. We had there what's called a yakuzen, a medicinal meal where all these different ingredients are supposed to have medicinal properties. Nearing the end here, we learned about, sorry for speeding up a little bit, but I want to be done on time. We learned about, at the Toyama University, it's a place where they're really trying to bring Campo into the 21st century. So that's where we met this guy. They have a museum that shows, which looks sort of interesting, but it's not just for history. They're sampling these herbs from all over the world, because a ginseng root grown in China, in one part of China or another part of China, are grown on a farm versus in the wild may be very different. And so they're trying to study ways to sort of standardize them so you can treat more evenly. Here's an example of peony root that they just sort of treated it in 15 different ways, and they're measuring in an active ingredient to show how, do you dry it first or boil it or you skin it, affects the amount of the chemicals in there. There's an associated hospital where they had these, they give out normal drugs like you would see in the West, Western drugs, but they also have these drawers of just herbs and things that the pharmacist or the doctor may say, oh, give them this. And they put all these, package all these ingredients together. And then some folks made us, this is how you make them into a tea that you would drink. And they made 5 different teas for us of the 5 more popular medicines, and we had to try them and see how they work. So, I guess the takeaway point I want to have with this is that some of these, what are considered alternative systems, do have a theory. It's just undermining them is just different than the theory we have in the West. And while we shouldn't just embrace them without critical thought, we shouldn't just deny them as something as foreign either. And so that's where I want to end here. I hope this whole series gave you some information and ways to sort of evaluate and think about critically about medicine and the way that you interact with it. I don't know if we have time for questions, but I'll take any if we do.
We can always, people can come.
Yes, that's true, yes.
Let's give Josh a minute.
Yeah, I can stick around for a few minutes if people want to ask or